I am welcoming you all for this evening academic symposium. The topic for the day is Bridging Guidelines 2023 and Practice. To deliver this talk today, we have a very senior most pulmonologist and very renowned speaker from Chennai. Of course, doctor doesn't require any kind of introduction. It's perfectly our honor to introduce Dr. Kailash to all of you. Dr. Kailash is done his MD DDCD pulmonologist from and director from Asthma Studio. Sir has been given lot of lectures in educating the postgraduates, general practitioners, physicians, pulmonologists across the respiratory diseases topic. Sir has been invited as a speaker for various regional level and national level, state level conferences. Sir has done a lot of publications. Sir has been invited as a faculty for many regional level and national level conferences. Sir used to give a lot of lectures and many of them was very well appreciated. In fact, many of the doctors, they would like to listen to senior most doctors like Kailash are having more than 3 decades of experience. With this, once again, I welcome Dr. Kailash to share his expertise and experience on bridging the guidelines 2023 and practice. And also, I request the delegates, if you have asked any question to Dr. Kailash, please post your question in the chat box, or else you can also unmute and ask to Dr. Kailash during the question and answer session. So, welcome once again, Dr. Kailash, over to you.
Thank you very much, Nagaraj. Thank you very much. Now, we'll have one more session on asthma. Asthma is one disease which has baffled the entire medical profession because of its presentation. It's such a dramatic presentation that patients are so unhappy. If you cannot breathe, just imagine if you can't breathe properly. Just imagine how a father or mother will feel if the child is not able to breathe. So obviously, this is one disease. Though you may think it is not a killer, but still it is one dramatic disease which has to be treated properly, so that the patient does not come with repetitive times for the same problem. Okay, so that is why I thought we should talk entirely about this particular disease. Of course, all of you know that asthma is the basic pathophysiology in asthma is hypersensitivity, inflammation, and bronchoconstriction. These are the three key words which you should remember: hypersensitivity, inflammation, and of course third, bronchoconstriction. Because of these two words, hypersensitivity and inflammation, we use steroids. Please remember this. Steroids are always used in asthma for these two reasons only. For bronchoconstriction, we use some bronchodilators. We can use bronchodilators like formoterol or salmeterol. Even orally also, if you want, you can use some theophylline and all that stuff. But this is the basic thing. So if you know this, please tell all your patients that doctors should address these two areas: inflammation, hypersensitivity, and bronchoconstriction. That is why you need two drugs for maintaining asthma properly. So, but you all know that many of our patients, the moment we tell them steroids, they are really worried. But I want all doctors to be convinced that steroid is the drug of choice for asthma. And it has to be given. An inhalation steroid, you should have the conviction to tell the patients, yes, you have to have steroids for this particular disease. If you don't have the conviction, then you can never tell. Because nowadays, most of the patients, when they come to you, they keep on telling you that, sir, if it contains steroids, I don't want. Because the problem is many doctors, many general practitioners tell the patients that this product contains steroids. So they are scared that steroids may cause. So if you don't have the conviction, then you will always try to come back and give some other drugs which are not very effective for asthma. So you have the conviction that yes, I am going to prescribe steroid and convince my patient that inhalation steroid is very, very safe. This is the background in which I want to start this program, because if you don't have this background, then you will not be able to. Of course, diagnosis of asthma is very, very simple. All you have to do is have a good history. You must have the time to take a good history. Many of us do not have time. All of us are busy in some way or other. But please spend about 5 minutes for history taking. But in a very crowded practice, we may not be able to devote time. The moment he comes, we start investigating. Please Ask him some key questions. What are the key questions you'll ask for asthma is whether he has the first question you ask him for asthma. Many of the patients will come and tell you I have asthma. But don't worry about it. Tell him what are the key symptoms. Do you have dry cough in the night? This is the most important thing, particularly in pediatric asthma and adult asthma. Do you have dry cough in the night? If he has dry cough, the moment he lies down, he coughs, then it is one of the symptoms of asthma. Does he have chest tightness? Marble irkam, this is the word they use. If you have chest tightness, then probably you are also itching towards asthma. The third, he says, I have difficulty in climbing stairs. I have difficulty in walking. I have difficulty in running. Any activity, I'm breathless. So this is the third symptom of asthma. And the last symptom is wheeze. Please do not go. You don't have to wait till wheeze. Please remember, because many of my patients who come to me for asthma or in the first stage coughing only, they go from pillar to post, every doctor to doctor for cough. And unfortunately, most of the doctors, the moment they come with cough, they'll write on antibiotic, they'll write on cough syrup. It will not work at all. It will not work at all. So please understand. So what happens these days, the people go from 4 or 5 doctors, each doctor will change the antibiotic, it will not work. Finally, you come to me and tell, stop antibiotic, just do this simple test. Or with history itself, I know this is please, and I'll start him on inhalation therapy. So this key word, please remember, if he has these 4 symptoms, if you have a good history, and if you can afford, do a pulmonary function test. Pulmonary function test is a simple test to diagnose asthma. The test itself will give you a diagnosis with the obstructive lung airway disease and all that. Or if you can't afford a pulmonary function test, do a peak flow meter. Peak flow meter is such a simple instrument with which you can diagnose wheeze. The peak flow value for each patient differs from one person to another. Please, according to his age and according to his sex, this will change. The value will change. Height also is important. So please understand, you have a nomogram. With the nomogram, you can decide whether his peak flow is very low. If his peak flow is very low, probably the caliber of the bronchial tubes are so low, so he needs bronchodilation. So these are the various things with which, of course, nowadays we do nitric oxide estimation, which is a very good test to find out whether there is inflammation in the respiratory tract. If you can afford it, fine, or it's not necessary. History and peak flow meter itself is enough for a practitioner to diagnose asthma. After you diagnose asthma, how to treat is what we got. And now I'm going to tell you some guidelines. See, GINA is a guideline which has given us some steps of how to handle a case of asthma. GINA is an international body which gives us guidelines for asthma therapists, how to. But this may differ from practice. Please understand, all guidelines are only just guidelines. They give you a guideline, but it all depends upon individual people. We have to use it but you go through the guidelines so that you will know what to use, when to use, and all that stuff. So I'll tell you what are the things GINA has given you and how it will help us to treat asthma. The first, of course, is asthma is a worldwide. Please understand that asthma is a worldwide burden. There is about 176 million asthma exacerbation occurring. This is what I'm not talking about number of cases. Exacerbation alone for asthma per year is about 176 million, which is a phenomenal number all over the world. Out of which 262 million patients. There are about 260 million patients of asthma in the world, out of which 176 have exacerbations for asthma. Exacerbation is the only thing which makes the disease very dramatic. He comes with severe difficulty in breathing, sir. The way in which the patient is brought itself is so dramatic. So as asthma exacerbation, physically it's very threatening and emotionally significant for the patients and the relatives. The patients are really, sir, he's not able to breathe, please don't do something. That is why preventing an asthma exacerbation is very, very important. 1/3 of the patients reported for exacerbation thought their lives were in danger. The problem is, it is so very tightening. See, if you can't breathe, you feel you're going to die. That's the feeling. So that is why 1/3 of the patients who are reported for these exacerbations, they think they're going to die. And that is why it's very important that we prevent an exacerbation in asthma. And how to prevent an exacerbation in asthma is what we are going to talk today. Okay. So the next is 91% of asthmatics perceive that their asthma is under control. This is the myth which is happening. This is a fact which is happening. It's a myth also. Lot of our patients in India, they think around 91%, which is a huge number, 91% perceive that their asthma is under control. Though it is not under control, please understand. So a lot of people think they are taking treatment and they are perfectly under control. But if you do a pheno for them, 80% of all those people, the pheno will be very high. Pheno, I told you, is a thing which tells us how much of inflammation in the respiratory tract. 64% of asthmatics have incorrect use of device. This is the most pitiable thing, Unfortunately, in asthma, the drugs are delivered through a device. All other diseases do not require devices to deliver the drug. But in asthma, you have a device, and that is an advantage too. Please understand, on all other diseases, you have to give an oral pill. The oral pill has to be taken, it has to get absorbed, and a small quantity of the drug will come to the site for action. But in asthma, there's a big advantage. You can directly deliver the drug into the respiratory tract. And such micro doses, please understand, the amount of drug that is deposited in the lung is in microgram. What is a microgram? A microgram is 1/1000th of a milligram. Such a low dose is what is required in the lung because it's going directly to the lung. That is why it's a big advantage for pulmonologists that you can give a small dose to treat a big disease. That's a big advantage. So asthmatics have incorrect use of, and 64% of the Indian people, if they're using the drug, if they're using the device wrongly, then the drug is not going to be delivered. That's a big problem we are facing. Of course, out of 66%, 8.4 exacerbation patient years last for about, these exacerbations last for about 66%. The entire exacerbation lasts for about 4 days, which is not very good. For many of them, the moment they get a severe exacerbation, they get admitted. So admissions also increase by asthma. 42% of asthmatics in India make emergency visits, and 18% of them do get hospitalized also. These are the facts that we have gathered from various studies. Of course, the paradoxes in asthma management potentially contribute to over-reliance on SABA. Now, this is one thing, an underuse of ICS. This is what I told you. See, ICS is ICS, inhaled corticosteroids. That is what is ICS. Inhaled corticosteroids are the mainstay for asthma. And SABA is nothing but, say, salbutamol, which is a bronchodilator. But the bronchodilator gives instant relief. So the patients think this is the best drug for him, and he starts taking SABA, which is salbutamol. Various trade names are available in the market as inhalers or Rotacaps and all that. But lot of them, they get so much of relief. If you give separately the SABA and ICS, patient will use only SABA because it gives them relief. So please, for heaven's sake, do not give separately. If you give separately, the problem will come. Don't use the SABA at all, because SABA is not a very good drug. SABA is like salbutamol, is not a good drug for asthma. It just gives temporary relief. But ICS is the one which gives fantastic relief, very good relief. So in the step 1 of GINA, SABA alone is recommended despite asthma being a disease of chronic. But the unfortunate thing, in step 1 of GINA, SABA is given. In fact, a lot of pediatricians give only SABA. SABA is nothing but salbutamol for asthma relief. I think it should be removed. It's not a very good step. That is why I said I do not follow that practice at all, because you are not addressing the worsening, you are not addressing the inflammation if you give SABA alone. ICS treats underlying inflammation, but patients still feel that SABA is the best medication because it gives relief. So that is the reason. So disconnect exists between patients' understanding of asthma control and actual symptoms. The patients think whatever gives me relief is a good drug. So that is why the initial phase, like for 20 years before or not, we were using a lot of SABA. Even we were using a lot of SABA because that was the only drug available. Of course, now things have changed, and I'll tell you what are the drugs we use of present. Now, frequent use of salbutamol causes a lot of adverse reactions like beta receptor down regulation. Beta receptors in the lungs come down so that you don't have enough drugs for acting. The decreased bronchoprotection, you'll get a lot of infection also if you use. Rebound hyperresponsive. In fact, already it is hyperresponsive, and it gets a rebound hyperresponsive and the exacerbation increase. Decreased bronchodilator response, frequently use them. Increase allergic, all this is bad for asthma. Allergic response increases, hyperresponsively increases, dilator response also decreases, all that. That is why higher use of SABA is associated with adverse clinical outcomes. Do not use SABA for higher dispensing around more than 12 canisters per year is associated substantially. Okay, so please understand, dispensing about 12 canisters. See, one canister we use, it has about say 100 doses. If you use 12 canisters per year, see, one canister a month if you use also is associated with increased risk of death. So please do not use SABA at all. So the one message which I want to pass on to you today is, do not use SABA at all separately. This is one, because many of us use, please understand, many of the practitioners use SABA separately. Aspirin inhaler is given dime a dozen, so many people, so please do not use it. Then of course, reliever doses, ICS formoterol. This is a good combination. ICS in corticosteroid, inhaled corticosteroids. Formoterol is a bronchodilator, not salbutamol. Salbutamol is not a very good. Formoterol in very low doses is a very powerful bronchodilator, and a combination is very, very good. This combination is very good. If you use this combination, if you take one inhaler whenever, you can use it whenever necessary. Please understand, it's not necessary that you should do one dose morning, one dose night, and all that. Whenever you have as and when needed, also you can use. Another inhalation can be taken in a few minutes later. I given people 5 minutes, 10 minutes later also another inhalation, they do not get relief, but normally they get relief, so you can use it. The maximum number of doses of this combination can go up to 12 inhalations for adults and 8 inhalations per day itself. So you can go up to 12 inhalations per adult, which is phenomenal. 12 inhalation we don't require. Normally we don't use so many doses. We use one puff in the morning, afternoon, night. I use maximum one puff twice daily. But there are some people who have severe bronchoconstriction. We use thrice daily. You can use thrice or 4 times. But I'll tell them, whenever you have, you can use a puff. Okay, so that is what is important. Then of course, in track 1, step 3 to 5, what is given in GINA is maintenance and reliever therapy. Maintenance and reliever. That is, this combination is both a maintenance and gives relief also. Both that is called MART therapy. Maintenance and reliever therapy. That is what is MART therapy. MART with ICS and formoterol reduces severe exacerbation when compared. There are studies which shows when compared with ICS alone or ICS LAMA and all that, they found out. But ICS formoterol alone as a maintenance reliever therapy is fantastic. A lot of studies have shown both budesonide and formoterol contribute to the reduction in severe exacerbation. So please remember, these two drugs are wonderful drugs, because those days when we practiced, salmeterol and the other drug fluticasone was used phenomenally. Like I was using a dime a dozen of these two drugs. But now, of course, of late, for budesonide formoterol is a wonderful combination. Please remember this combination alone for asthma management. Why GINA track 1 with ICS formoterol is preferred is because MART, I told you, shows versus other when compared MART with other regimens, it's fantastic. The relief is good. Both ICS formoterol contribute to reduction in severe exacerbation. Simplicity of approach, that is what because you're just giving one puff, you're not giving separately for bronchodilators and ICS separately. One single medication for both symptom relief and maintenance. That is the advantage, and avoids confusion about inhalation technique, because if you teach him one inhalation technique, one device, then he understands. So very easy. You don't have to use a dry powder for one and inhalation for one and all that stuff. Clear? Then of course, switching to budesonide formoterol as needed plus maintenance reduce the risk of exacerbation. See, what he says is budesonide formoterol as and when required. If you use it, exacerbation come down by about 30%. That is the biggest advantage. Please remember, this anti-inflammatory reliever plus maintenance was preferred for stepping up and stepping down in any type of therapy. Whenever you want to step it up, you can increase 2, 3, 4, 5 and all that. Then you can step it down. So that reduces the risk of severe exacerbation. This is what we have found out in many studies. In fact, there is a study which says 30% of all exacerbation will come only if you use this formoterol budesonide as and when necessary. Globally, inhaler devices need to provide rigorous data for drug deposition and other parameters for approval. This is very, very important, because internationally now, since asthma is used only through devices, there are a lot of international norms for using it. There's a committee for medicinal products for human use. There's a company itself, and it certifies that this is a wonderful device. This is a wonderful device to use for asthma. So one of the device that this committee has approved really is called a turbohaler. Turbohaler is a device. The drug that is used in turbohaler is formoterol budesonide. That is, it's called Symbicort. But turbohaler is a simple device to use, very simple. All you have to do is unscrew it. It's just unscrew, then remove the cap. After removing the cap, underneath there is a red bulb. Just screw the bulb to one side, you won't get a noise, and screw it on the other side, you will get a click. The moment you get a click, that means the device is ready. Keep it in your mouth and inhale. That's so simple. It cannot be made simpler. All you have to do is open the cap. Cap opening is nothing. Screw one side, another side. That is right, left. If you do right, you will not get a noise. If you do left, you will get a click. The moment you get a click, inhale. That's all. Very simple. So the drug has to be very, very simple. The patients, it should be very patient friendly. It should be very patient friendly. Only then the device will be it will be easily used by the patient so that they get paid. So turbohaler is a very simple device which can be used. Then of course, the fine particle dose in a drug is also very, very important. There are internationally two very good preparations. One is turbohaler, another one is a discuss. Seretide is available abroad as discussed. Seretide discussed, and Symbicort is available also abroad. In fact, it's an international product. They found out the fine particle dose, the percentage of the dose is equal and really good. See, it should be 60, so it's 55 and 63. When compared to the other one discussed, it's 22 only, very low. Then MMAD, this is another most important. MMAD means mass median aerodynamic diameter. This has to be small. It has to be small. It's around 2.2. Normally, ideal is around 2 to 3. So in turbohaler, it is about 2.2 to 2.4. Whereas with the other discuss, about 4.4 higher on the higher side. That is why the drug deposition is so good with this device. I told you, device is equally important in treating asthma. Apart from the drug, because there are a lot of devices and lot of the same combination given by any device. But if you use the correct device, the best device, then you are sure you are giving enough relief to the patients. Then of course, turbohaler also provides uniform dose delivery and the same budesonide photon ratio and first to last dose. This is very important. There is in a device, if you keep on taking it 60 times, for example, so number 1 to 60 times, all the doses, uniform dose will come. That is very important. It is not there available in other devices. So this is a wonderful device which gives uniform dose from dose 1 to the last 60 doses. That is what is the advantage of this particular device. Then of course, the particle size matters for delivery. Very important. Normally the particle size should be 1 to 5 microns. That's all. That's an ideal particle size. If you have more than 5 microns, then they'll be deposited in the pharynx. Useless. Many of the dry powder inhalers have more than 5 microns. That is why you feel the thrush and all comes because of the deposit in the throat. If its particle size is very small, you can really make it small, thinking that it really is. Then it goes to the alveolus. It's useless. It also goes to deposits in a place which is not necessary. The ideal is 1 to 5 where it gets deposited to bronchial tree, where the desired effect is required. The bronchial tree only you require bronchodilation. The bronchial tree only you require anti-inflammatory effect. And this particular device, turbohaler, gives between 1 to 5 microns. Every dose is 1 to 5 microns. That is the advantage. But how they made it to 1 to 5 microns is because of this particular thing. There is a drug formulation can be in the form of a powder, or it can be formed. A lot of companies have crystals. It can be micronization or spheronization. What is spheronization? It's spherical balls. That's why it's spheronization. It's spherical balls. The balls are so beautifully designed, and they do not have lot of lactose also attached to it. Whereas in a dry powder where you have powder, you have to add little lactose for it to be carried inside, because it will be fine dust. So you need add. That is why a lot of people, when the moment you do dry powder, they say, I can feel something in the throat. Whereas if you use in spherical form, like what is used in turbohaler, then and only 1 to 5 microns, then the advantage is the drug beautifully goes in the system mist. If you use it only, it's a small mist that goes into the lungs. And the drugs are in a spherical form. They go. It's a better flow. Spherical form. And if it's spherical, the flow is also good. Minimal lactose deposition, low oropharyngeal deposition, no thrush at all. If you use it even for, I've been using this device for years, and I've never come across a patient complaining of. In fact, I've come across patients saying, I don't feel anything at all. That is the only thing they say. But I get relief. They say I get relief, but I don't feel anything on control. So please understand, this is the best form to have the drug in the system. Then of course, there is a study which says that turbohaler, the drug has to be deposited in the bronchial tree. 38% get deposited in the bronchial tree when you use a turbohaler. Whereas when it comes to meter dose inhalers, like the inhalers, it's only 21%. And when it comes to dry powder, which is very common in India, we use a lot of dry powder, the rotacaps we say, because it's cheap. It's very cheap. So a lot of people, a lot of doctors only write rotacaps. There the deposition only 14%. Just imagine you give a drug and only 14% of the drug gets deposited in the bronchial tree. See, the patient will not be, he'll have to use higher dose. Only then you get the desired effect. Whereas with the turbohaler, he gets about 38% deposition in his first shot itself. That is the advantage with turbohaler when compared to the other. The turbohaler looks like this. Then of course, in summary, the GINA recommends track 1, which is preferred to have both in the formoterol and budesonide together. There is a gap in asthma management in India. That is what we have been telling you. Device, we do not have a very good device, but now of course there's a very good device that is available, so you can use it. Mark has given us evidence to say that effectiveness, that combination maintenance and reliever therapy combination is the best. Don't give it individually. The choice of inhaler should have adequate trail documents. What it means is that the international committee should say this is a wonderful device to deliver the drug. So if that is said, then we know this device is good. And if you have the drug in that particular formulation goes into your system, it will give you 100% results, 100%. So I think I have given you some guidelines of how you should manage asthma in a simple way. It's not a very expensive. The treatment itself is so simple. If you use this one drug morning and night, it's enough. The patient will not have any. Probably you might add a little bit of oral drugs like morphine and all that along with that. But this is the drug of choice. Please remember, this is the drug of choice for all asthmatics. So if you understand this, you have conquered treating asthma. I think we'll stop these slides and we'll have questions.